Assalamu alaikum. Welcome to all the audience and everyone who is watching from all around the world. This is an episode of continuation of the episodes of the Imamia Medics International Women's Wing Cancer Awareness Series. And today's episode is brought to us by the Michigan chapter of the Women's Wing. So, without any delay, we'll start this with the name of the Almighty Allah. So, I'll begin with the holy verses. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم قل هو الله أحد الله الصمد لم يلد ولم يولد ولم يكن له كفوا أحد. Translation. Say, He is Allah the One. Allah is eternal and absolute. None is born of Him, nor He was born, and there is none like Him. Sadaqallahul Azim. Once again, you are watching us live on the Imamia Medics International YouTube page, MyTV. We are live here in the Women's Wing Cancer Awareness Series. Today's episode presented to you by Michigan Chapter. And now I would like to introduce the lady who is leading the Michigan Chapter of Imamia Medics International Women Wing. We have with us Dr. Sabah Azhar Bukhari. Dr. Sabah Azhar Bukhari is a senior staff physician at Henry Ford Health, American Board of Internal Medicine and American Board of Geriatric Medicine certified. She is also leading the Michigan chapter of Imamia Medics International Women's Wing. Welcome, Dr. Sabah, and thank you for joining us.
Thank you, Varda. Thank you so much for the kind introduction. Assalamu alaikum, everyone. I welcome you from IMI Michigan chapter to this medical webinar. This is our first medical webinar that IMI Michigan chapter is conducting. And the purpose of this webinar or any medical webinars that IMI has been conducting for so many years is to impart knowledge to our community about diseases that are prevalent. And in reference to this webinar, it's about cancer and smoking. And the goal is to create awareness about lung cancer and risk factors associated with smoking so that our community members can benefit from the knowledge. So we're going to try to lay out all the information. There will be some medical terminologies used, but we will try to lay out the information in a way that you all can understand and we can benefit to our community members so that when they see any of their relatives, any of their loved ones suffering from any disease, by looking at them, if we have some awareness, we are able to help them out by guiding them to see the right specialist. If we see smoking is so prevalent, especially in the youth also, so if we have the awareness that what methods we can, use to do smoking cessation, we can guide our friends, our colleagues to the right physicians and healthcare professionals and help them in that way. So this was the whole purpose of this medical webinar, and we will be looking forward to your feedback. With this, I'm going to hand over the floor to our very active participant of IMI Michigan chapter, Rabab Imtiaz. Rabab is a third-year medical student at Wayne University, and she has spent a lot of effort in helping us conducting this first medical webinar. So Rabab, I welcome you.
Thank you so much. Assalamu alaikum, everyone, and thank you so much for joining our first webinar. So I'm just going to be introducing each of our speakers. Our first speaker will be Dr. Yusra Shao. She's an assistant professor in the Department of Oncology at Karmanos Center, which is located at Wayne State University. She's completed her medical degree from the Ohio State University, IM residency from Cleveland Clinic, and hematology and oncology at Karmanos, where she served as chief fellow. Dr. Xiao's clinical and research expertise lies in skin, bladder, kidney, and prostate cancer, for which she also runs many clinical trials. She's passionate about teaching, research, and patient care, and is also a member of the Faith Community Health Initiative in Dearborn Heights. Start, Dr. Xiao.
Assalamu alaikum, everyone. Good morning. And for those of you who might be joining from outside of the United States, good evening. Let me share my screen here real quick. Okay. Thank you, Rebecca, for that kind introduction. And I'd like to thank the organizers for giving me the opportunity to speak on this very important topic. So let's get started. If I was to mention lung cancer, many of you, or if I was to mention smoking and cancer relationship, many of you may first think about lung cancer. And that is very true. 9 out of 10 lung cancer is related to smoking, meaning if those 9 individuals had not smoked, they would not have developed lung cancer. Having said that, smoking has been known to cause 16 different types of cancer in the entire body. So if we were to just start from head to toe, mouth and oral, voice box cancer, cancer of the esophagus, the food pipe, of course, lung, bronchus, and tracheal cancer, blood cancer, leukemia, which unfortunately is a very lethal type of cancer, liver cancer, cancer of the pancreas, stomach, kidney, bladder, pelvis cancers, which are my areas of special expertise, and then uterine cancer, so cancers of the female genital urinary tract, and also colon and rectal cancer. As we know, the incidence of colon cancer has increased in the last several years, younger and younger patients being diagnosed with colon cancer and unfortunately dying of colon cancer. And some of this may be attributed to lifestyle changes such as smoking. So to drive home this point further, cigarette smoking causes 3 out of 10 all cancer deaths. So not only is smoking related to diagnosis of new cancers, it is also linked with worse outcomes, meaning about 300,000 people every year in the United States will die of cancer related to tobacco use. And even if a patient is diagnosed with cancer and if they're a smoker, unfortunately, their outcomes are worse, meaning the cancer is more aggressive, is diagnosed at a later stage, meaning more spread out through the body, lower chances of cure, and worse outcomes because of poor wound healing, poor immune response to the cancer and the treatments we give. So smoking and cancer, unfortunately, are the nemesis of each other. So how does smoking or tobacco in general cause cancer? Smoking has chemicals, or cigarette smoke, right, has many chemicals that are considered carcinogens. So carcinogens are chemicals that bind or attach to our DNA, and DNA is the blueprint for the body. DNA is what tells our cells what they're supposed to look like. Are they supposed to become hair cells or skin cell or stomach cell, right? When these carcinogens attach themselves to the DNA can no longer be read like normal. And over time, the cells start to become abnormal and grow into cancer. So cigarette smoke, apart from these carcinogens, is actually known to have 7,000 different chemicals. Just imagining that enormous number of 7,000 different chemicals that our patients might be inhaling into their bodies. And out of those, 70 are known to be carcinogens. On top of that, 16 of these 70 are carcinogens specific for tobacco. So even if our patients are using tobacco not as a cigarette smoke, but chewing tobacco or other forms of tobacco, they are still exposing themselves to these carcinogens. And here on the right are just some examples of what these carcinogens might be. So what about secondhand smoke? Someone might say, well, doc, I don't smoke, but my husband does, or my son smokes. What about that? We know that 7,000 lung cancer deaths every year are attributed to patients who never smoked, but were exposed to secondhand smoke. So this chart here is coming from a study where they looked at these carcinogens in the urine of patients. And you can see here, women who live with family members who smoke, they also have these carcinogens in their urine. That is much more than patients who may have never been, living in an environment where there are smokers. And even worse yet, if we were to look at this box right here, newborns who are born into the houses where there are smokers, the urine level of these carcinogens is high. And unfortunately, these levels are known to cause cancer. And I'm just going to make a quick talk about betel nut. So in our country is called supari. This is found in pan. Even though betel nut by itself does not have tobacco and requires an entire conversation by itself, that is also a known carcinogen, primarily causing oral head and neck cancers. So what are some common signs that we can be looking out for as physicians, but also as family members or patients themselves, right? Common signs of cancer, especially if you're a smoker, these are the things to absolutely look out for. So you can think of the acronym BREATHE, specifically for lung cancer, blood in the cough or spit. So if you have a new cough, unfortunately, many of our smokers will be coughing daily, but if you're starting to see blood, that can be a sign of worry. Recurring lung infections, again, that can be very common in our smoking patients because of other issues like COPD, but keeping an eye on that. Enduring a cough that is different. So again, we talked about this, a cough that's not getting better, there's blood in the cough, new pain specifically in a bony part. So I understand, as we all age, we might have arthritis kind of pains in the knees, in the hips. But if you're getting new pain, like out of nowhere in the spine, that needs to be looked at by your physician. Trouble breathing, hoarseness or wheezing, specifically change in your voice, may be a sign of head and neck cancer, a new lump or mass. And then lastly, exhaustion. So just feeling more tired than usual, losing more weight than usual. Those can be ominous signs. So that's more specific for lung cancer. What other common types of symptoms to look out for? Because as I mentioned, smoking causes 16 different types of cancers. So blood in the urine, this may be a sign of bladder cancer or kidney cancer. Are women who are after the age of menopause. Unfortunately, many women after menopause may begin to see bleeding that they should not be seeing and not pay attention to it. This can be an early sign of cancer. Blood in the stool. New worsening abdominal pain, especially after eating food. The stomach is hurting, that needs to be addressed. Difficulty swallowing, hoarseness, as I mentioned, unexplained weight loss, sudden worsening fatigue, any lump in the body should not go unchecked. And then lastly, if there is a sore, if there is a pimple on the face that's not getting better and has been there for a year and it's bleeding, it really should be looked at by your doctor. So how do we overall decrease the risk of cancer from smoking? The number one thing is to stop smoking. So let's say if a 50-year-old patient today was to decide, I'm going to stop smoking, how does this affect their risk of cancer long term, right? So for 5 or 10 years, from their stop date, they can expect that the risk of head and neck cancer is going to be cut in half. By 10 years, there is a much lower risk of bladder, kidney, esophagus cancer. Again, by 10 to 15 years, the risk of lung cancer is going to be cut in half. But what's also important to note, even if I was to stop smoking today, it takes time for the body to recover. So the sooner you make this decision, the better for the body. Okay. It can take up to 20 years for the risk of pancreas cancer to decrease. And then also the risk of cervical cancer over time will become half of the risk that you may have today. Okay. What other things can our patients do to really help decrease their risk of cancer? Number one, being on top of their cancer screening. So cervical cancer screening, pap smears, right? Recommending for the age of 21 to 65. Colon cancer screening starts at the age of 45. And again, each of these topics requires an entire webinar of its own. And I hope that, as we plan some of these, many of you will be joining. And then lung cancer screening, our next speaker will go over the details of lung cancer screening in our patients who smoke. And what can everyone else do? Those who are non-smokers, right? So absolutely quitting smoking today, encouraging our friends and family, our coworkers to quit smoking, help them educate that this is not just about you, this is about those around you who are also at increased risk because of someone's smoking habits. Educating our teens, our children, our adolescents about the risk of tobacco use and smoking. Unfortunately, many of them are using these lifestyle measures. And then making our homes and our cars tobacco-free, 100% tobacco-free, so our children are not exposed to secondhand smoke. And then lastly, just educating ourselves about symptoms of cancer and what screening is entailed. So to summarize everything that I mentioned, tobacco is linked to 16 different types of cancers that go beyond just lung cancer. There are more than 60 carcinogens, or as I mentioned, 70 carcinogens, and of those 16 are tobacco specific. So no matter what form of tobacco you used, there is a risk of cancer. And smoking cessation is the best way to decrease your risk of cancer. There is risk of secondhand smoke-related cancers, and adherence to cancer screening is very, very important. So I leave my email address here for any questions, and with that, I can take questions from the audience.
Thank you so much, Dr. Xiao, for that incredibly informative presentation on lung cancer and smoking. So I just had one question for you. You discussed smoking and tobacco for cancer. How about other forms like e-cigarettes and vapes? Are they also connected to cancer, or would you say that they could potentially be like a good alternative to tobacco smoke?
Yeah, Rabab, that's an excellent question because many of our youth and adolescents are using those more and more. What I would say is those agents are still newer. I don't think the science is as developed as we know about tobacco and smoking. You know, it took decades for us to figure out that smoking causes cancer, you know, so our science always lags behind. So I would never say, yes, vapes are safe, e-cigarettes are safe, right? I think for those individuals who are actively smoking and they're using that as a way to quit smoking, it can be helpful. Having said that, there are many people who are what's called dual users, meaning they're using the e-cigarettes and they're also smoking, right? So now instead of being exposed to just one type of carcinogens, you have two different agents. But for those individuals who've never smoked, our recommendation would be to stay away from those types of inhalants.
No, that makes sense. Thank you so much. So now we're going on to our second speaker, Dr. Tariq Hadid, who is a medical oncologist and member of the Head and Neck and Thoracic Oncology Multidisciplinary Team at the Karmanos Cancer Institute. He also serves as an associate professor of oncology at the Wayne State University School of Medicine. Dr. Hadid specializes in treating patients with thoracic and head and neck cancers. He's a member of the American Society of Clinical Oncology, Michigan Society of Hematology and Oncology, and is a fellow of the American College of Physicians. Dr. Hadid is one of the key faculty for the Heme Onc Fellowship at Karmanos Center Institute. He is also an active researcher and leads several clinical trials at Karmanos Center Institute. Welcome, Dr. Hadid.
Thank you so much. Assalamu alaikum, everyone. And it's a pleasure to be here, and thank you for the organizers for this kind invitation. I'll be speaking about cancer prevention with focus on lung cancer and head and neck cancer. So these are my objectives. We will be speaking about the incidence of some of these cancers we just discussed. We will also talk about some of the risk factors, symptoms, and we'll talk about how to prevent these cancers from occurring. So this is a cartoon that shows the diagram of how we can target cancer. As you can see on the left side of the slide, you can see that the cells get exposed to some kind of carcinogens or chemicals that affect the cells. These cells progress to become slightly more abnormal, and then became more abnormal, and then become cancerous, and then spread out to a different part of the body. So at the first level, when we target the cells before they become cancerous, we call that a primary prevention, preventing the cancer causing agents to affect the cells in the first place. An example of that is stopping smoking or not smoking in the first place. The second part is when we have exposure to the agent that cause cancer and they start to cause cancer or the beginning of a cancer, we can try to find the cancer at earlier stage and detect it so we can treat it and get better results than what happens when the cancer has become more advanced and has spread to different places. The tertiary prevention is when we try to focus on people that do have cancer that has spread or has more later stage and see how we can prevent symptoms and improve the quality of life. So lung cancer is a common cancer. 1 out of 5 people have 1 out of 5 cancer patients have lung cancer. It's extremely common and it's extremely deadly. Worldwide, we see about 3 deaths from lung cancer every minute. So it's a huge amount of people that actually we lose because of the lung cancer. Lung cancer death is more than prostate cancer, breast cancer, and colon cancer combined. So as you can see here, it does cause a lot more death than any other cancers that you can think of. In the United States, it's the leading cause of death of all cancers. On the left side here, you can see the graphs for men, and on the right side is for women. And you can see how lung cancer leading the death in men and also in women. Luckily, we are seeing some decline over time, which is good, and I think it's attributed to smoking cessation and a lot more restriction on smoking in the United States. And the women also, we see a little bit lower height here, but it seems to be also going in the right direction. So that's a good encouraging thing, but it still remains the highest cause of all cancer death. On this slide, you can see that there is different survival by stage. For example, on the left side here, you can see stage 1 lung cancers. There's multiple types of stage 1. There's stage 2 here. You can stage 3 and stage 4. And you can see the chances of survival at 5 years is higher if you have stage 1. It's lower if stage 2, a little bit lower if stage 3. And if you get stage 4, the chance of living 5 years after diagnosis is very low. Similarly, here you can see the curves that stage 1 do better. Stage 2, a little bit less, and 3 and 4 become lower and lower. So this helps us to try to find the cancer at the earlier stage so we can have a better chance of living and not dying from the cancer. So what caused lung cancer? Everybody knows that smoking is the leading cause of lung cancer without question. It's about 85 to 95% of lung cancer are caused by smoking. There's other causes of lung cancer, however, exposure to some carcinogens like the hydrocarbons, nitrosamines. These sometimes are found in the fuels and some are in the other smokes that we see in the environment. Exposure to asbestos is really critical and it's very important, especially for the old houses in this country. Exposure to radiation for other cancers treatment. For example, a woman that has breast cancer at a younger age or Hodgkin lymphoma at a younger age and get treated with radiation, they can later on develop lung cancer because of the prior radiation exposure. Radon exposure, which it comes from the environment, and we'll talk about that a little bit briefly later on. Having a lung disease, having a family history of lung cancer, it's a minor but important cause of lung cancer. Symptoms of lung cancer can vary. So coughing blood is definitely a concerning sign. So when patients see a blood in their cough, they should seek medical attention immediately. Having an infection that does not improve and keep recurring, especially in the lungs, it can be a sign of lung cancer. Having more shortness of breath than usual, feeling more tired, having voice changes, having change in the weight, decreasing the weight, or decreasing the appetite. Having cough that's not going away, all these things could be signs of lung cancer and should be evaluated carefully. Lung cancer, when it's spread to other organs, it can cause symptoms related to the organs. For example, if it goes to the brain, it can cause confusion, headaches, seizures. If it goes to the lungs, it can cause more problem with breathing. If it goes to the chest or the middle part of the chest, it can cause some difficulty with breathing or pain. If it goes to the liver, it can cause abdominal pain. Similarly, if it goes to the adrenal glands, it can cause some discomfort, or if it goes to the bones, it can cause bone-related pain. So it depends on where the cancer goes to, it can cause more symptoms. And the goal is obviously to hopefully find the cancer before it goes to any other organs. So primary prevention of lung cancer, like we talked before, primary prevention is preventing the cancer from happening before it happens. So it's quitting smoking, all type of cigarette use or other tobacco use um, has been linked to lung cancer. So quitting all type of tobacco is extremely important and critical. That's include hookahs, include betel nuts, include other cigarettes and e-cigarettes and vapes and all type of tobacco use. Avoiding exposure to asbestos. Asbestos can reach the person can be exposed to asbestos through their houses that are built before the 1980s. Most likely they will have some asbestos in them, in the paint and the other structure of the house. So if you have a house that is built before that time, it probably should be evaluated to assess whether it has asbestos in it, and find ways to kind of avoid that or cover that by certain methods. Radon exposure has also been linked to lung cancer. Radon is a natural radioactive materials that comes from the environment, specifically from the rocks and from the earth itself, and it can enter the house through the cracks that you see in the basement or in the lower levels of the house. At a lower level, exposure to radon is not a big problem, but certain areas have higher exposure to radon, and when the person gets exposed to a larger radon dose, that can cause lung cancer. So for that, it's recommended that people inspect their houses, make sure all the cracks, especially the basement and lower levels, are closed and covered, and there's no connection between the ground and the house itself. Despite those being risk factors for lung cancer, obviously smoking, as we talked before, is a leading cause, and that's contributed to over 85 to 95% of lung cancers. Secondary prevention of lung cancer means preventing the cancer or finding the cancer at earlier stage. Like we talked before, stage 1 have much better outcome than cancer that are found at stage 3 or 4. So the aim is to try to find cancer at earlier stage. In the past, they have tried to do X-ray to find the cancer at earlier stage. That has failed. So X-ray does not detect cancer at earlier stage and does not prevent death from lung cancer. So it's not recommended. However, CT scans is known to prevent lung cancer or finding lung cancer at earlier stage. Like you can see here, there's a small little nodule that you can see in the lung here, a small spot in the lung that you can see. It's probably a stage 1 lung cancer that can be treated easily, and the patient has a very good chance of surviving. A CT scan of the chest does not require any injections, and it only takes about 10 to 15 minutes to be performed. It can make a big difference in the person's likelihood of survival. So who should be screened for lung cancer? Who should undergo the CT scan we just discussed? Anybody that between the age of 50 and 80 and has smoked before, typically a 20 pack a year history of smoking, which means like 1 pack a day for 20 years, or something or anything equivalent to that. For example, like half a pack a day for 40 years, or 1 pack a day for 20 years, or 2 packs a day for 10 years. All these are equivalent to about 1 pack per day for 20 years. All those patients all these patients qualify for lung cancer screening with a CT scan if they're within the age period, as long as they have still smoked or have quit only within the last 15 years. And that's done through a CT scan. It's done once a year. Like we mentioned before, it's a very short scan and does not require any IV injections. And that can result in a 20% decrease in the likelihood of dying from lung cancer, and predominantly by finding the cancer at earlier stage, typically stage 1 or stage 2. So what's the difference we see between being screened or not screened? Patient that gets screened get a CT scan of the chest done once a year. You find the cancer at the early stage, very small lung cancer. You can undergo surgery for that, and you get 92% chance of living. On the other hand, patient that not get screened, start having some symptoms, cough, breathing problems, bleeding, things like that. Undergo the CT scan similar to the other person. You find it's already stage 4. The cancer has, spread to multiple areas like a fluid and things like that. Patient cannot get surgery because the cancer is so advanced and so large, and the chances of surviving through that is only less than 1%. So people ask a lot about how can we keep the lungs healthy? How can and continue to have healthy lungs and not have to suffer from anything related to my lungs. So breathing healthy air is key. How do you do that? Not smoke. If you're a smoker, you should quit smoking immediately. You should avoid any secondhand smoke because that's been linked to also cancer and worse lung function. Avoid exposure to bad air days. So try not to go out when the air is bad. Outside, avoid exposure to high traffic areas, which has a lot of smoke in it. There's a way to check the air quality in your area. I did check the air quality in Detroit a couple of days ago, and it was good. So either you can reach that website here, Air Now, and look at the air quality in your area, and that helps you sometimes to go out or not go out if the air quality is bad. Avoid burning wood near the house because that can expose you to some of the chemicals. And do a CT screening if you qualify based on the criteria we just discussed. So in summary, lung cancer is the main cause of death worldwide. You can prevent it primarily by avoiding any carcinogens or chemicals that can cause lung cancer, primarily tobacco use. You can secondarily prevent it by undergoing once a year CT scan of the chest for those who qualify and detect cancer at earlier stage. And we discussed that CT scan of the lungs once a year does decrease the chances of dying from lung cancer and saves lives. So we'll shift gear toward head and neck cancer. Head and neck cancer is a large burden of cancer worldwide. In this slide, you can see a map of the world, and you can see those dark areas. Obviously, darker the area, the higher the incidence of head and neck cancer. And as you can see in the Southeast Asia, there's a large number of people that are diagnosed with head and neck cancers. Same thing in Russia and Europe and some of the United States as well. Head and neck cancer is a large number of diseases that includes the oral cavity, the tonsils, the oropharynx, the gums, the tongue, the throat area. You get the voice box, and you have the pharynx, and you have the hard palate, the nose, and nasopharynx. So many number of organs are located within the head and neck area. There is a few of those organs have increased incidence of cancer, specifically the oral cavity and tonsils and oropharynx, and some others are decreased in incidence. Oropharynx in general is increasing over time, and we can see a large increase in the blue line, which is the HPV-mediated oropharyngeal cancer. It seems, at least in the United States, it's increasing over time. That's thought to be related to the HPV exposure and higher incidence of HPV in the United States. Because of the smoking restriction in the United States, the HPV unrelated oropharyngeal cancer seems to be decreasing because of the tobacco cessation that the patient has gone through and the government restrictions on tobacco and high tax rates. The major risk factors for head and neck cancers, as you know, tobacco is also a major risk factor for head and neck cancer. About 75% of oral cancers are tobacco users. And here you can see that different type of tobacco, for example, smoking cigarettes increase your chance of head and neck cancer by 6 times. Sniffing tobacco is about 50 times increased risk of head and neck cancer. Cigar smoking about 10 times increased risk of head and neck cancer. And chewing different forms of tobacco can increase your chance of oral cancer by about 9 times. HPV, which is a virus that can infect the oropharyngeal area, can lead to head and neck cancer, specifically oropharyngeal cancer. Also, alcohol use can result in head and neck cancer as well and should be avoided. This slide kind of go over a summary of some of the head and neck cancer facts. We talked about some of the risk factors for head and neck cancer here. You can see there's about 650,000 cases in the United States every year. Head and neck cancer generally is more common in men than women. This is only true for HPV negative cancers, but the ones that are caused by HPV are equal between men and women. And obviously, symptoms of head and neck cancers are important to detect, which we will go over here. Having a bleeding coming from the nose or the mouth, having some pain on chewing or swallowing, having some kind of lump in the neck or the mouth, having some sinus infection that keep coming back over and over and not going away, having headaches that are not resolving, having nose that feels like it's blocked or not draining appropriately, having any spots on the mouth, specifically if it's a white spot area, some ear pain or ear fullness, nasal bleeding or nasal obstruction, some visual changes that can happen, sometimes can be linked to head and neck cancer. So how do you prevent it primarily? Primarily means prevent it before it happens, before the cancer happens. Talk to your doctor, not drink alcohol, do not smoke. And if you are less than 46 years old, you should get the HPV vaccination and visit a dentist or physician regularly for examination of the oral cavity and the neck area to catch any precancerous spots that could be treated before they turn to cancer. Secondary prevention, which means finding the cancer when it has occurred but it's earlier stage, require an examination by a physician at least once a year to check for any spots that are abnormal or any neck masses that were detected or has developed over time. Seek medical attention if you have symptoms. So as any of these symptoms that we described, if they're present, you should go see the physician and get evaluated quickly. And if there's any spots that you see in your mouth that are not normal, for example, like if you in this picture here, you can see some white areas there. That's not normal to see in the mouth, and that's typically called leukoplakia, which means that it's a precancerous condition that could be treated before it turned to cancer. So if you see that, you should probably see a physician very quickly. So in summary, head and neck cancer can be caused by all forms of tobacco, and they all should be avoided. HPV virus and alcohol can also cause lung cancer and can cause head and neck cancer, and they should be avoided as well. And HPV should be prevented with vaccination. Primary prevention of head and neck cancer is predominantly avoiding carcinogens, for example, tobacco use, not smoking, avoid alcohol, and get HPV vaccination and preventing and avoiding unhealthy sexual relationships. Secondary prevention of head and neck cancer includes oral examination at least once a year and early report of symptoms that could be linked to head and neck cancer. And finally, the patient with head and neck cancer should undergo lung cancer screening because there's a big link between head and neck cancer and lung cancer, and because they're both caused by smoking. So people that develop head and neck cancer sometime in the past should also undergo once a year CT scan of the lung to detect any second cancer that can occur in the lung after the first head and neck cancer. Thank you very much for listening, and I'm happy to take any questions.
Thank you so much, Dr. Hadid, for that incredibly informative presentation. So I just had one question. You mentioned that low-dose chest CT scans are pretty helpful in detecting lung cancer. How accurate would you say that these scans are? And would you say that there's any chances of like a false positive or a false negative in getting these scans?
Yeah. So yeah, low-dose CT scan of the chest is extremely good and sensitive in detecting any cancers in the lungs. It looks to a whole lung and find any spots that are very early cancers. However, not every spot that we see in the lung is lung cancer. The majority of the time, actually, they're not lung cancer. They are something else, like a scar tissue inflammation, some other benign condition. So about over 90% of the time, what you see in the lung on a CT scan are not lung cancers. They are something else. But there is ways to evaluate those, especially see how they're changing over time. You know, if there's any finding on the scan that make it more likely to be lung cancer or not. So that helps us to determine whether those are cancerous or not. So yes, there is more non-cancer than cancerous, but there also, if there's like a lung cancer, the chances of finding it by a low-dose CT scan, especially if it's done once a year, is extremely high.
Okay, that makes sense. Thank you so much. And also just a reminder to everyone who's watching on YouTube, feel free to leave any questions. We'll be going through them at the end as well. So our final speaker for today is Dr. Sara Hussain. She's a board-certified internal medicine doctor practicing since 2009. She finished her med school at Aligarh University in India and her residency at Providence Hospital, Ascension in Michigan. She did her final year training as chief resident and has numerous international publications. She has also earned distinction as a consultant in geriatric medicine to National Institute of Medicine in 2014. Additionally, she has been selected as an honored member of National Registry's Top Doctors in America 2024. Thank you, Dr. Hassan, for your presentation and welcome.
Thank you, everybody. Thank you for those kind words, Rabab. I'm already blushing. And thank you for the great speech, Dr. Yusra, Dr. Hadid. And thank you so much for inviting me. So I would keep this topic very fun for you guys and a little bit short because I know that cancer itself is not a very pleasant topic. So my presentation is smoking cessation. Is everybody able to see my screen?
Yes.
Okay. So when I have been having my patients start on this journey, it's not easy. When you tell a person don't smoke, they have your 15 minutes appointment. They are coming in for a blood pressure refill. They are coming in for diabetes. They don't want to talk about smoking cessation. So, following these patients for a long duration of time, that is the key. And a primary care, as an internist, you see your patients, you see them like you. I have been seeing my patients at least for the last 15 years. And I had the privilege of seeing three generations. So the grandma used to come to me, and then the daughter is coming, and then the kids are coming. So I always kind of build up that rapport when you ask these sensitive questions. But I feel like ask them, why are you smoking? I mean, what makes you smoke? Is it your peers? How much are you smoking? When do you smoke? Is it the boredom? Is it the overwork? Is it so going into that depth, going into that really dark zone, and having that trust that your patients can tell you everything? That's very important. And you don't start with your advice. You don't say, hey, you're smoking, I see that, can you please quit? No, discuss with them, well, I think you're not doing the right thing. It will save you some money if you don't smoke. It's not good. I've been seeing a lot of cancers. So confide in them. Make sure that they have the trust in you, and then see how they are responding to you. Are they just like, let's talk about this later, or they're willing to quit? And then build up that conversation. I usually have my patients leave will like, hey, promise me you will quit next time, or you would go down on your cigarettes. So that creates a lot of trust, and I think that is very important. And I usually have a follow up with them for quitting. Usually it's a week or it's like a month, according how their schedule is. But that is, I think, very very important, the 5 A's of smoking cessation. And as a common man, I think it's very important to know that these things really matter. These are easy, they're easy to start the conversation, but we have to start it at one point. Now, the medications that we use for smoking cessation, the nicotine patch, if the patients are smoking more than one pack a day, which is one pack on an average has 20 cigarettes. So if I looked it up a little bit because I was not very aware, but 10 to 20 cigarettes, it's one pack. Most of my patients, they are very hesitant. If you ask them, they'll actually give you just the half dose. So you have to be like, you have to tell me. So be very, very, I would say, open to them, and they will tell you. If it's 21 milligram, that is one pack, you start with them as a patch, 21 milligram patch. If it is half a pack, it is 14 milligram. There are gums, nicotine gums available, there are lozenges available, and these are all over the counter, which is a great thing. The nicotine inhalers are also available, the sprays are available, but they are with prescription in US. The medications that are used are varenicline, a 0.5 milligram tablet, and you titrate the dose to see how the response is, and the bupropion, 150 milligram per day, and you can titrate the dose as well. Now, the patients, when you tell them, hey, go and buy this patch, it will be wonderful, they would never buy it. So you have to talk to them. Hey, go downstairs, we have a pharmacy downstairs. These patches are just $35 for 14 patches. you can actually save the same money by not buying the cigarettes and then buying the patches. So good encouragement is very, very important for them. The nicotine gum, they are expensive, $110 for 170 gums. They are available in 2 milligrams and 4 milligrams. They are over the counter. The 4 milligram we usually use for heavy smokers, more than 10 cigarettes a day, for those who smoke within 30 minutes of waking. So that is very important. That looks like they have very high nicotine dependence. Otherwise, we usually start the patients on 2 milligram and we taper them. The first week, we use one piece of the gum every 1 to 2 hours. They can use up till 24 pieces per day. And then week 7 to 8, they chew one piece of gum every 2 to 4 hours. Then as they transition, as they are more comfortable, then we actually go down on the duration. And the week 10 to 12, they chew one piece of gum every 4 to 8 hours. So you can always tell them, hey, you would not need that much. So looks like you are like buying so many gums and you're spending around $110, but eventually you might not need them, and you can give it to your friend, to your family who smokes, and then help them as well. Now, let's see these patients. We did everything for them. We offered them therapy, we offered them the nicotine patches, and they're still smoking. Now, when you have them over, discuss with them. Well, were you using the patches correctly? Did you take them before you were supposed to, or you just left them more than 24 hours? Do you feel like your family was judging you that you had a patch on? Were you stressed out in this time where you did not feel like you were ready? Patients who are very highly motivated and they're not able to stop smoking, despite all these behavioral counselings and nicotine replacement therapies, we actually take the second step. We go to the medications. I have done it with medications and nicotine patches in very rare cases. Most of my patients, if they are very motivated, they really want to quit, I think the patches are enough. Now, there is a great behavioral therapy that is available for my patients. I tell them, yeah, well, you can go to a therapist if you like. Get to that point where you are very comfortable and you feel okay, and safe to talk about it to somebody. There is a counseling in US. There's a toll-free number they can call. We're 1-800 quit now. There is a national institute that has developed a text message service for US residents. It's a smoke-free text program. There are websites the government has actually installed for them. It's smokefree.gov, and the patients can go, they can get the resources available. I have tried hypnosis on a lot of my patients. I have gotten great results. The only problem with hypnosis is that it's not covered by insurance. As soon as the patients hear this, there's a red flag and they're like, okay, I don't want to pay out of my pocket. Although it will be less expensive if they actually quit and they go for hypnosis. But I had few success with hypnosis as well. All these behavioral therapies, they have to be started in addition to any nicotine patches and medications. There are resources available. There are a lot of websites the patients can go, especially the teenagers. There's a lot of peer pressure. My son is in high school, and he goes like, it's crazy out there. These kids are actually in that environment where vaping is very normal. There are e-cigarettes. There is we all are sharing this common problem where we have to say, well, we have to stop it. So talk to your teens, talk to your friends, talk to your family members, say, hey, I'm available if you want any resources. I don't want to go all over them, but there are help to quit. My family might quit. If somebody can take a picture of it, this is available on YouTube, so you can always go back to this and help somebody. I mean, it's a great thing that somebody can stop smoking because that you helped them. Now let's come to those patients who are depressed, who have bipolar issues, who are just smoking because they saw their parents smoking. What do you do for these patients? Now, we suggest that I start them on the varenicline, absolutely, like, go for that. There are actually the quit rates for tobacco, quit rates are somewhat lower in these individuals because they don't have that strong willpower. So you have to closely follow up on these patients. There is an evidence which indicates that the same medication are effective for tobacco users with or without psychiatric comorbidity. So, like, let's see, there are severely, like, mentally impaired patients. You should try the medications first and then see how they respond it, but a close follow-up is really needed. In US, I've seen these patients, they come with their case workers, they come with their case managers. I explain to the case managers, when you go in, check on these patients, make sure they are not buying. Sometimes these case managers take these patients for grocery shopping, and so I said, well, make sure that they don't go and buy cigarettes. Can you please make sure that you can tell me if they are, they're not hiding it from me. So all these things are really very, very important when we are dealing with patients with these disorders. Now let's come to the other group of patients. Like, let's say I have patients who are going for a major surgery. They're pre-surgical candidates. I usually start them with nicotine replacement therapy, those patches, and the medications together because they don't have too much time. If they are really motivated and really want to do it, then I'll go for the nicotine therapy because it's right away. They'll see some results and their craving will be down. The medications take a little bit longer time. Patients with seizure disorder, the bupropion medication is contraindicated. It should not be given at any point in these patients. So it's very, very important to know your patients well and to know what their medical history is. Pregnant females, pregnancy happens when they have not planned, they're already smoking. Usually cold turkey, not doing it one single day, and this just waking up and saying, I'm not going to smoke. That is hard, but that is the most effective way of quitting. I tell my patients, you have to do it, and they usually use like a nicotine patch, I would say every day, and then they just kind of wean off. The bupropion in pregnant females, there are very limited data if you should be using medications, but there is an increased risk of congenital malformations, specifically cardiac malformations. So we always shy away from medications in pregnant females. Now, the bupropion, if we have to start it, we started with 150 milligram tablet for 3 days. We increase it 150 milligram twice daily. The treatment is very, very it's very unique. So you need to know the quit date. You need to know when the patients are ready. So the treatment should start while the patient is still smoking in order to allow the drug to reach a steady level. So that is very unique to this medication. And generally, patients should stop smoking during the second week of treatment. The maximum dose you can go on bupropion is 300 milligram per day. It's a cheap drug. It's not very expensive. I tell my patients, once I put you on this drug, you will save so much money. The money you spend in cigarettes, save that money and go for counseling. So it's going to be like they feel like they have a good plan ahead of them. The e-cigarettes have been FDA approved, but they have not been approved as a medical product for smoking cessation. So they still is a lot of data that needs to come out to see their safety. Everybody knows about Chantix, the varenicline that was discontinued in 2021. They found that they had high levels of nitrosamine. So the generic is available in US. The first day 1 to day 3, we start them on 0.5 milligram once a day, and then we titrate the levels up day 4 to day 7, 0.5 milligram twice daily. They have to have a quit date. You have to make sure that you exactly know when to start and when to stop. There are a lot of medical ways of doing it. I don't want to go into the detail. I don't want to make it boring for you guys, but there's a lot of success rate in this medication. Saying that, thank you so much for having me, and I hope I can answer any of your questions.
Thank you. Thank you so much for your super informative presentation on communication. So I just had one question for you. You mentioned for patients with psychiatric issues, varenicline and bupropion are helpful for smoking cessation. So can you kind of like go deeper into why that's the case? And does that mean like other forms of treatment like nicotine patches won't work for them?
Okay, excellent question. So, Rabab, there are very limited studies on psychiatric patients because there is a difficult follow-up appointments. They don't show up for the appointments. Their insurance falls. So there are not a lot of data that is available. And then you have to understand that the mental illness these patients are having, they have some sensory issues. There's either proprioception or like the touch, the vibration, the taste. So they usually, these patients, they do not like to keep the patches on. So you cannot like with confidence you can say that they put the patch on for 24 hours, 30, or less than that. And they don't use the lozenges, they don't use the sprays. The compliant is an issue when you are dealing with these patients, and then that is why the studies are very few. What I have done is that I make sure these patients put the patches on, and there's a lot of follow-up that's needed. So I usually tell them, well, can you log your hours when you put your patch on? Can you put that on a piece of paper? And when you take it off, just put it on a piece of paper, bring it back to the next appointment, and we'll go over it. I make it sound like they have to do it. And if they don't do it, I know. So that actually, I hope that answers your question.
Yeah, it does for sure. So I just want to say thank you to all three of the speakers who presented today. It was super, super informative and really helpful. Now we're just going to go over a few questions from the audience. The first one is directed to Dr. Yusra Shao. The question is smoking related to bone cancer as well, or is there any link there?
Yeah, that's an important question to understand in two different ways. So I think many times, when folks are saying bone cancer, I just want to clarify that many times patients are talking about cancer that may have started somewhere else and then gone to the bone, right? So we always describe our cancer by where it started. Even if it then goes to the liver, bone, anywhere else, it's still considered, let's say, for example, lung cancer because it started in the lung. So that is going to be dependent on, so the question of is that related to smoking is going to be dependent on which type of cancer we're talking about. So lung cancer, for example, loves to go to the bone. The most common places lung cancer goes is brain and bones. That's why if a patient is having new bone pain, they really need to be alarmed. And for that reason, yes, lung cancer metastasizing to the bone would be due to smoking, as we mentioned, 9 out of 10 cases. If we're talking about other types of cancers that go to the bone, there are many other ones. For example, breast cancer loves to go to the bone. The evidence on whether breast cancer is related to smoking is not as strong. Kidney cancer loves to go to the bone, and I mentioned, that smoking-related cancer, bladder cancer, so it just depends. Primary bone cancer, meaning cancer that starts in the bone, is actually very rare and happens more often in young patients, and is not considered a smoking-related cancer.
Thank you, Dr. Shao. I have another question from the audience that is also directed towards you. If you can go deeper into, how if vaping could cause cancer. I know you mentioned it a little bit earlier, but just
Yeah, it's always worth repeating. So vaping and e-cigarettes are still a newer form of individuals to consume nicotine. The research on it is still being done. So if I quote directly from American Cancer Society, they say scientists are still learning about e-cigarettes and vaping. The health effects remain to be discovered further. And as I mentioned, even for smoking, it took us several decades to figure out that the increasing incidence of lung cancer actually had to do with increasing use of smoking. smoking, right? So our research is going to lag behind. Having said that, vaping and e-cigarettes are known to have many of the same carcinogens in the smoke, granted to a lesser amount, but they are still known to have many of those carcinogens because many of those carcinogens are what's called aromatic hydrocarbons, meaning these are chemicals that give the smell and the scent to the smokes and the vapes and the e-cigarettes, right? So now we're burning all of that and taking that into our lungs. So in general, for lung health, they're not great. It's going to take some time for us to figure out exactly their correlation with cancer. So again, for patients who have never smoked, the best thing is to not use e-cigarettes and vaping. For patients who are currently smoking, and as Dr. Hussein mentioned, there is no clear evidence actually that e-cigarettes help patients quit smoking. Many of them will end up doing dual use. So it's best to utilize other forms of quitting smoking.
Okay, thank you. My next question is for Dr. Hadid. If any stage of cancer, like stage 3, gets fully treated, for example, what are the chances of it potentially returning?
The chance of it's potentially recurring or coming back. Okay. Yeah, that's a great question too. So I think that the purpose why we try to find cancer earlier stage because the chances of it's coming back or occurring is much lower. But when a person reaches stage 3, for example, the chance of cancer coming back it's about 75-80%. So the majority of the time, 3 out of 4 people with stage 3, the cancer will come back, despite treatment, whether it's surgical or radiation, things like that. When you come to a stage 1 or stage 2, the chance is becoming less and less. When you come into the very early stage, which stage 1A, you get about only 10% of a chance of the cancer coming back. So it's related to what stage the person has. The chance of cancer coming back will change. Hope that answers your question.
Oh, for sure. Thank you. And now we have one last question for Dr. Sara. So if I have a family member who is diagnosed with lung cancer or who constantly smokes, how can I best support
Well, it depends. You don't want to be sounding very unpractical. So it's a hard diagnosis. Sit with them, talk to them. What are their fears? What do they want? How do they want to proceed? A good oncologist, a good multidisciplinary team, primary care physician support can go a long way. I have been taught very early in my practice, do not give up on these patients. It's a very devastating diagnosis for them, and they need all your support. So just talk to them, spend time with them. And at this point, I feel like the patients already are very guilty that they might be doing something to have this on them, like smoking. So a kind word of advice and give them support, that goes a long way.
Thank you so much, Dr. Sara. So that is all the time that we have for today. If anyone has any more questions, please feel free to reach out to any of us. Thank you so much for joining me. Now I'll hand it off to Dr. Lewis.
Thank you.
All right. So thank you so much, Sister Abab, for the beautiful way you have engaged everyone. And then thank you, of course, Dr. Yusra. Thank you, Dr. Hadid. Thank you, Dr. Sara. Thank you especially to Dr. Saba for bringing it all together from the Michigan chapter. Thank you very much, the Women's Wing chapter of the Michigan Women's Wing chapter of Imamia Medics International. I would also like to mention that a great thanks goes to the media team behind the scenes who work a lot to make everything go smooth. And I'd also like to thank Dr. Huma for always guiding us and bringing us all together. Over to you, Dr. Saba, if you'd like to say anything.
Yes, no, thank you so much. I just want to conclude by saying, by appreciating everyone who was part of this webinar. I appreciate each and every one of you. I know we all have such busy lives, with work and families, and you all took out your precious time to serve the community. So I thank Dr. Yusra for taking the lead and getting, Dr. Tariq Hadid on this webinar also. And I would like to thank Dr. Sara Hussain and Rabab, of course, for being so involved in this webinar and helping us out. I want to thank the whole IMI media team, and Varda, I want to thank you and Dr. Huma Naqvi, because this was our Michigan chapter's first medical webinar, a new experience, but all of you made it so easy for us to go through the whole preparation. So I appreciate each and every one of you. And I just hope that we can continue to do things like this to help our community, and whatever knowledge we can give them at our end. That's the goal. Thank you so much.
Thank you. See everyone again, inshallah, in yet another episode from the Imami Medics International Women's Wing Cancer Awareness Series. Till then, Allah Hafiz.
Allah Hafiz. Thank you, everyone. Khuda Hafiz.